70 to 80 years. So it gives me great pleasure to invite the next speaker, Dr. Toh Bin Chet, who has trained in multiple places in the UK, France, and Singapore, and is now a consultant general surgeon at Nexus Surgical. His subspecialties are upper gastrointestinal surgery, bariatric weight loss, and metabolic endoscopic surgery, as well as advanced endoscopy. He continues to be a visiting consultant at Sengkang General Hospital, and today he'll be speaking about transforming life through bariatric metabolic surgery to defeat obesity for a healthier tomorrow. So this is a very interesting topic because when I have a couple of young patients whose parents have gone through bariatric surgery and they have all lost at least 15 to 20 kilos. And it seems so fashionable to go for surgery such that I feel inspired to consider consulting someone for that too. So maybe this will be my first consultation today. Please join me in welcoming Dr. Toh today. Thank you.
Thank you very much for your kind introductions. The reason why I choose this topic because I'm very enlightened after giving listen to Dr. Roland and Dr. Esther talk about medicals management. Is actually a very, very kind because a lot of specialty now come into together to treat obesity. Over the last 20 years, people always think obesity, just ignore these people. You look at on the street, on the Orchard Road, you go and count 1 to 10, right? You'll get one obesity patient walking around. And you feel like you want to go in front and say, hello, do you feel your knee pain? Do you have a back pain? And things like that. But people don't have these intentions in the past 20 years because people feel that when you give them the opinion, they'll feel insulted. So that's why I'm very happy nowadays. People are more upfront and to talk about obesity. How do we help patients? You look at these slides to start off with. Do you think this patient is happy? They may not be happy. They are trying very hard in their life. For example, this guy is running around trying to lose some weight. Do you think he can success? It's not easy without help. And if you go to a flight, you sit in the economic, and someone sitting beside you, it's just like this guy. I mean, although you keep quiet, but your face expression to the guy sitting beside you will cause a lot of the patient feel a lot, even though you don't talk to him. And eventually, this guy, after running about one round and then sitting on the stair and thinking about how can I'm going to lose weight. All right. So why do I think this is a very important life burden and challenges with obesity? A lot of people know that they have this problem. They just couldn't find a way out from it. So if you look at this survey done in US, 72% of the people with obesity having experienced unfair treatment at work. They feel people's obesity, they are very lazy. People always think that they are unmotivated people, they are unprofessional, and they have a lot of weight stigma among themselves, right? So because of that, psychological, they get affected too much of, and then eventually become very low self-esteem, get depression, they get poor body image and anxiety. So we know that obesity is a disease nowadays, right? I mean, it's not as simple as just two pathways. How do we control what we eat? And then how do we control not to eat? It's so complex that majority of the health professionals now know that it's so complex. Nobody knows any single pathway they can actually control, right? So that's very glad that a lot of brain is actually coming together to try to solve these problems. So no doubt, after listening to Dr. Esther and Dr. Lauren, we know that obesity is a disease itself. It's just like hypertension, high cholesterol. Okay? So morbid obesity, if you look at that, is a definition by ICD code, all right? All of us use that, right? So it's overweight and obesity. It was abnormal, excessive fat accumulation that impair our health. It's a very complex, relapsing, multifactorial neurobehavioral disease. So I want to raise your attention here. This is the obesity is a disease itself. All right. So I always think obesity is just the tip of the iceberg. You look at obesity itself, a lot of things that you is hiding underneath. If you look at this under the sea, list of problems, medical problems, there was actually a link to obesity like diabetes, ischemic heart disease, osteoarthritis, infertility, gallstone, depression, sleep apnea, and a lot of cancer. And there is still a lot of misconceptions in our previous generations. People still always think people get obese. We have some weight stigma to them because they are inactive, they don't want to work, they don't want to exercise, or overeating, sweetened food, smoking. But look at that. A lot of research is showing that this is not only that. A lot of people are obese just because they are taking medications like steroid and things like that for the long term. The people are working shift in the city now, they lack of sleep, they're causing a lot of obesity. Some genetic running the family with obese, of course, got hormones and causing this obesity problem. So worst is obesity is always associated with diabetes. Almost 90% of type 2 diabetes patients are somehow overweight and obesity. If you don't treat obesity and overweight early, you will get diabetes. And then eventually you down the spiral, you get a lot of problems or medical problems, like diabetes complication, like stroke, heart attack. And then by that time, you come to consult any doctor. We are not physician, we are not magician, right? We're a physician, we are doctors. We cannot reverse a lot of complication that down the road of complication of obesity. So we know that obese patients also have a higher chance of getting a gallstones. Obese patients have a lot of reflux problem because of intra-abdominal pressure. So this also linked to, this is the images that one of my patients, you can see, if you don't treat obesity early, chronic reflux can cause Barrett esophagus changes and eventually can lead to cancer. So for reproductive age women, a lot of patients trying to get pregnant before, when now the age of getting pregnancy is getting harder and harder, right? So a lot of people try IVF and things like that. Despite multiple times, they still cannot succeed because of the obesity. So if we don't treat obesity as a root cause, no matter what scientific knowledge you have, you will be unable to help the patient. So if you look at the obesity, the pre-pregnancy, people who have PCOS and infertility problem, even obesity, you get pregnant, you're lucky enough. During the obesity, you get gestational diabetes, you get hypertension, preeclampsia. The baby will get too big to deliver, hard to deliver. And even you successfully deliver a baby, you may get postpartum hemorrhage, and then eventually obesity patient, high risk of getting a breast and endometrial cancer. It's a change of complication from obesity. And a lot of research been showing that up to 13 cancers is actually linked to obesity. And it is the second commonest cause of cancer in UK nowadays is obesity. So there's no doubt that obesity need to be treated early. And then I'm grateful that now everybody is actually contribute a lot in doing the research and how do we treat obesity. So to me, what is the barrier to obesity management? I always think about is either a patient factor or a physician factor from our end. So for patient factor itself, there's some patient that have lack of recognition of the obesity problem itself. There's also misbelief and misinformation. But we also have to understand that a lot of patients actually try very hard to weight loss, but they lost their momentum. They lost their confidence. If they lose, they try many ways, they cannot lose any weight. So we as a physician factor, how do we help them? I feel that there is still some barrier in treatment of obesity because of number one, and all of us are actually busy with our general consultations. A lot of patients obese come to our clinics. We feel no time, lack of time to talk to the patient. We always say, oh, you have obese, please try exercise and control your diet. That's all. And then you ask the patient to go away. The patient may not feel as sincere that you are trying to help them, so they don't come back to you anymore. So it's also because some of us feel that we don't have sufficient training and counseling skills in obesity. People may not like to hear obesity and things like that upfront. So sometimes we have to change the way that we talk to the obese patient and get them to understand their problems. They will keep coming back to you. Then you will help them achieve a significant weight loss and overall improve their health. So when do we treat obesity? As Dr. Esther mentioned, Asian, our BMI is slightly lower, 2.5 compared to Caucasian because of our lower BMI, our higher percentage of fat content compared to Caucasians, and we have higher cardiovascular risk and diabetes risk in Asian compared to Caucasian. So the obesity treatment plan, we need that. We know that there is no, it's not only surgical treatment that can cure everything. We need combination of this. That's why we need to work very, very closely with all the subspecialty to try to treat obesity. So obesity, if you follow the Ministry of Health Singapore guideline, we still follow 32.5 with comorbidity, like any comorbidity like hypertension, diabetes, cholesterol, the metabolic syndrome, that you can offer metabolic surgery. If you don't have any metabolic syndrome, your BMI more than 37.5, you actually fit the criteria to go for surgery. But having said that, we always want to climb up the pyramids so that all this will be the support to an overall successful program for our patient. So we know that bariatric surgery, people still think bariatric surgery is a shortcut for weight loss and as a last resort. If you do look at this survey done, 60% of the of people still think that this is a shortcut. And for me, I don't think this is a shortcut. I always don't treat bariatric surgery as a shortcut for weight loss. I always tell my patient, if you come to me, you must try all the way that you are trying, and you cannot succeed, then we will help you if you follow our programs nicely. Because if you think that this is a shortcut, this is a wrong start at the beginning. So on the other end, we also don't want people to think that bariatric surgery always the last resort for treatment for obesity, because we have seen more and more patients with obesity, morbid obesity, being neglected. So eventually become obesity hypoventilation syndrome. You may not heard this term before, but there is, in our society, there is still minority of patients that are actually at home, can't even out from their home because they are so obese, they can't even walk. They need to use CPAP at home at night. All right. So what is the risk of the bariatric surgery? The question to ask. People always think that surgery is a dangerous procedure, it's an intervention. People are always scared of surgery. But when you have cancer, you come to talk. I do gastric cancer as well. So when you have cancer, patient will come and say, okay, I want to do a surgery now. I don't scare about surgery anymore. You understand what I'm saying? But when you have obesity, because it can be delayed, people always think that, oh, it doesn't matter. I will try my way to lose weight. I take 5 years, 10 years, but I still cannot lose weight. So there is a mentality differences in terms of management of benign and malignant disease. So if you think about the bariatric surgery, if you continue to remain obese, it will be the second leading cause of premature death. Everybody know that. So how about the risk of bariatric surgery? But nowadays, the bariatric surgery, the risk is actually less than 1%. It's just as low as gallbladder surgery, knee replacement surgery. People do bariatric surgery, all of us do bariatric surgery keyhole approach. And very rarely you heard people do open surgery anymore for weight loss. So the risk of the surgery is not a question anymore in this 21st century. So what is the top reason for bariatric surgery consultation nowadays? A lot of people more and more aware of this approach, and they are wanting more permanent solution for weight loss. They want to feel better physically. They want to prevent future health problem. They want to get back their life and on track. So this is the top reason why they come to bariatric surgery consultations. Anti-obesity medication, very important. All right. So it gives us about 5 to 20% of weight loss. I do that because I collaborate very closely with endocrinologists. We always use this to kickstart the weight loss for a patient with morbid obesity. It improves our safety of the surgery as well. So how about the effectiveness of the bariatric surgery? The two commonest surgery do in Singapore and worldwide is still sleeve gastrectomy and Roux-en-Y gastric bypass. We can achieve 20% to 40% of body weight loss. 20% is the minimum. All right. If you read the paper on research, if you do a bariatric surgery, your weight loss is less than 20%. It's actually considered almost an ineffective or failure of your bariatric surgery. So that we can guarantee almost 20% of total weight loss. That is significant. So if you look at this photo, so the lady sitting on the left is BMI 30, 90 kg. And the guy sitting beside her was 140 kg, BMI 40. So well, 10 to 20% sufficient for these two patients? Answer may be yes. it could be sufficient for a 90 kg. If you lost about 10% or 20%, you lost about 20 kg. So you go about to 70 kg. That is significant for the ladies, but it may not be significant for the gentleman sitting on the right. You lost about 20%, you only lost about 28 kg, you're still about 100, 110, 120 kg. So it's not significant for that patient. So we always say that we need to choose the right option for the right patient. So when I talk about bariatric surgery, I like to talk about this paper is published in New England Journal in 2017. The patients with average BMI of 35 and with diabetes of about 8.5 years were randomized into medical therapy and metabolic surgery. If you look at that, after 5 years, almost 25% to 45% of patients that undergo metabolic surgery remain off medication for diabetes. So only 2% of patients continue to on taking tablets at 5-year marks. Only 2% patients manage to off medications. So if you're asking whether type 2 diabetes remission is a myth or a truth, there's some fact that's been saying that metabolic surgery did improve type 2 diabetes and can significantly help in type 2 diabetes remission. This is another paper that show that at 5-year mark, almost 50% of the patient went for metabolic surgery have complete remission of type 2 diabetes and maintain up to 5 years. So in overall, we need lifestyle management. But of course, with bariatric surgery and medications, we know that bariatric surgery is slightly more effective in lower the HbA1c level, can lead to less medication use and high rate of diabetes type 2 remissions and sustained weight loss up to 12 years. This is the most latest paper published in JAMA. So American Diabetes Association actually recognized that metabolic surgery as a standard treatment for type 2 diabetes, provided the criteria was met. And of course, when we select patients for surgery, we always go through psychological assessment, perioperatively safety management, and post-op management in terms of lifestyle to help the patient maintain a healthy weight loss throughout the year. So what is the mechanism of bariatric metabolic surgery? And people still think that bariatric surgery has stopped at the bending era, where nowadays we don't do bending anymore. Bending is like putting restrictions at the fundus level and try to restrict the food input. We don't do that anymore. But most of the time, we remove the band, which the surgeon put 20 years ago, because it's caused a lot of complication of erosions and things like that. But the new generation of bariatric metabolic surgeons are mostly what we do is do sleeve gastrectomy, 70-80%, a pretty safe procedure. There is a new procedures like endoscopic sleeve gastroplasty. Of course, roux and white gastric bypass for poorly controlled diabetes is still recommended worldwide among the bariatrics community. So endoscopic sleeve gastroplasty is for patients who really scared of knife, really doesn't want any scar. This is one of the latest approach that we help patients to lose weight. Put in a camera, it's like how you do an upper endoscopy. Then went into the stomach, do an assessment, make sure there is no ulcers, and then eventually we can put 4 to 6 sutures to narrow the stomach. And it's a very quick procedure, take about 1 to 2 hours. There is no scar. It's less complication compared to surgery. Having said that, this is still not the gold standard treatment for weight loss yet. So this is pretty new, and the weight loss so far that can induce is up to about 15%, 10 to 15%. So I will keep that for patient those who really doesn't want surgery, because there's a group of patients really will come approach and tell you that I don't want surgery. I just want to do balloon into my stomach. But nowadays balloons is getting less and less also, because balloon is a foreign body, sometimes put in the stomach. Patient doesn't like it very much. It causes a lot of vomiting and the moment you put a balloon into the patient, the next day some of the patient cannot even tolerate any food intake. They ask you to remove the balloon immediately. But for compared to sleeve gastroplasty, most of the patient can go home the next day and they don't feel much of the bloatedness symptom. So sleeve gastrectomy is a keyhole operation. This is still the most popular surgical option. Two-thirds up to about 80% of the stomach will be removed from the body. The reasons, the mechanism, the science behind this is when you remove the fundus, the ghrelin hormone will be removed. The patient doesn't feel hunger at all. And when you don't feel hunger, you don't eat much. And that's very good because it's a restrictive effect. And the significant weight loss can up to about, as I say, 20 to 40% of the total weight loss. Length of hospital stay 1 to 2 days. Roux-en-Y gastric bypass is still about 20% of the bariatric metabolic surgeon will do, because for poorly controlled diabetes, this is still the gold standard approach where we reduce the stomachs into a very small pouch, about 150 ml, and then we reconnect the small bowel into the stomachs. So we bypass about 150 meter of bowel for malabsorption to induce some malabsorption, and there's some restrictive component. This is a better long-term outcome in terms of remission of diabetes and weight loss. So to end my talks, you think about holidays, right? So you're going to a holiday like a Bangkok, right? So just choose the nearest one. It's like you want to lose some weight, for example. You want to lose about 25 kilograms. So it's just like from Singapore to Bangkok, you can do a diet exercise to go Bangkok, right? So you choose to ride a bike, but it will take it will take you about 18 days and 10 hours to lose that 25 kilograms, right? If you ride a diet about side bicycle, but if you think about that, you say, oh no, that's too much for me to ride a bicycle across Malaysia to reach Bangkok. So I just bought a Tesla, all right? So it will still take you about 23 hours and 27 minutes, provided Woodland is no jam, all right? And there's not too crowded during the festive season to cross, all right? So I always compare that to metabolic surgery. It's just like a SIA, right? So you go to Changi Airport, just check in, and then you get 2 hours and 50 minutes, you reach Bangkok, and then they say, all right, fine, I achieved my goal. So that is an option, right? It's an option. Why would I think that treating obesity, you need multiple options for the patient? You don't just offer one option to the patient. The patient will just run away because they couldn't lose weight. They lost confidence at you. They don't come back to you anymore. So why I say doing a bariatric surgery is very rewarding to myself, because this is published in Newsweek Times. So this is one of my patients. So she was actually 130 kg, BMI was 49, with PCOS, type 2 diabetes, infertility. You can read about her story in the Newsweek Times, not a problem. She tried to get pregnant and things like that multiple times. You know, she go to work, she got weight stigma and things like that. Eventually, she come to go for bariatric surgery. So look, what outcome is after the bariatric surgery, 1 year plus, 87 kilograms, BMI 32. I don't have the magic to make her into BMI 25 like a model, but it solved a problem. It solved a type 2 diabetes remissions, and it get IBS successful, right? You achieve what objective the patient want, and they get happy. The moment they get the keys, they say, all right, I don't want to weight loss anymore. I want to keep my baby. I want to make sure my baby get a successful pregnancy. And this is one of another patients of my colleagues that went for a Roux-en-Y gastric bypass, have diabetes, hypertension, cholesterol, OS, reflux, you name it, she had it. After the surgery, 84 kg, BMI 37, remission. So, well, people always say it's unbelievable, but I always think that bariatric surgery is just a proven, highly effective option for substantial and sustainable weight loss. You need to be tailored to individual. So you need to help the patient making the right decisions. So multiple options available to treat obesity. Let's work together, and then we will always target a different group of patients. Not every patient will need surgery, but of course we don't wait until the patient become an obesity hypoventilation syndrome, and then you ask the surgeons, look, this is your patient. So at that point, you will feel like this is very hard for us to help the patient. So we we need to review a patient every 3 months. If they couldn't lose any weight with whatever intervention you have made, you need to jump to the next solution, the next option. This is what I feel as a bariatric surgeon. I enjoy doing a bariatric metabolic surgery because I feel that's really transforming a life for my patient. But I do cancer work as well. But doing cancer work, the rewarding is there, but sometimes the patient have a recurrence, right? You feel depressed for that. For bariatric metabolic surgery, most of the time the patient will come back to my clinic 1 year, 2 years later, they will thank you. Sometimes they bring the baby back to your clinics. That kind of rewarding is actually a happy clinic. I call it a happy clinic compared with my cancer clinic. All right. So I always separate my bariatric clinic, the happy clinic, and then the cancer clinic the next day. So that sort of I make sure that I do two-way benign works and also malignant works, so to keep me ongoing, and why I like surgery. Thank you very much. I think I will end my talk today.
Well, thank you very much, Dr. Toh, for all the food for thought and bringing to center stage surgery in otherwise a primary medical disease. So I have the pleasure of introducing our dietitian.